Short bowel syndrome. Short bowel syndrome is a malabsorptive disorder due to either the congenital absence of the small intestine or surgical resection of a large amount of small intestine. What it causes is a decrease in absorptive area and thereby a decrease in nutrition and fluid and electrolyte imbalance. Adult residual small bowel of 150 to 200 centimeters or less would constitute short bowel syndrome. Intestinal failure is the inability of the gut to maintain adequate nutrition and hydration without IV support. Etiology. In adults, the causes are superior mesenteric artery embolus or thrombosis, superior mesenteric vein thrombosis, chronic intestinal pseudo-obstruction, midgut volvulus, multiple resections for Crohn's disease, radiation enteritis, progressive systemic sclerosis, large segment resection post-trauma, and refractory celiac disease. In children, there are causes like congenital villus atrophy, extensive aganglionosis, gastroschisis, jejunal or intestinal atresia, and necrotizing enterocolitis, of which congenital villus atrophy, chronic intestinal pseudo-obstruction, and refractory celiac disease constitute functional causes. Types of intestinal resection observed in short bowel syndrome are ileocolonic anastomosis, in which the remaining part of the ileum is anastomosed to the colon. Then we have the jejunal-colonic anastomosis, in which the ileum is not there, the jejunum is anastomosed to the colon. And then we have the end jejunostomy, in which the jejunum itself is exposed to the exterior. Nutrient absorption in the gut. From the proximal small bowel, there is fat, carbohydrate, and protein absorption. There is iron, calcium, magnesium, phosphate, and folic acid absorbed. And you have water and electrolyte absorption. While in this middle small intestine, fat is not absorbed so much as carbohydrate and peptides. Calcium gets absorbed here and water and electrolytes. Distal small intestine, especially the last 60 centimeters, is for absorption of bile acids and B12, and therefore a resection of more than 60 centimeters of terminal ileum requires the patient to have lifelong vitamin B12 IM, that's 1 milligram IM once a month for life. Bile acid malabsorption will cause deficiencies in A, D, E, and K, as well as fat malabsorption. And there's water and electrolytes also getting absorbed here. There would be hypocalcemia, hypomagnesemia, as unabsorbed fatty acid binds to calcium and magnesium, preventing it from getting absorbed. Colon is responsible for absorption of oxalate, vitamins, medium chain triglycerides, calcium and amino acids, and water. The mechanism by which the short bowel syndrome occurs is rapid gastric and ileal emptying, loss of an ileal brake because of impaired GLP-1, GLP-2 release, which slows the gastric emptying and slows the intestinal transit. Also, loss of ileocecal valve. If that portion is removed, it will cause a risk of small intestinal bacterial overgrowth because of the reflux of colonic bacteria into the terminal ileum, and also rapid transit. Normally what it would do is it would prevent this bacterial reflux from the colon into the small intestine, and it would slow the transit. If the colon is preserved, it ferments carbohydrates, and this causes the production of short-chain fatty acid, which provides 1,000 kilocalories per day. It also absorbs 3 to 4 liters of water per day and sodium. Intestinal adaptation, which occurs after small bowel resection occurs in about 1 to 2 years. What happens is the villi become taller, the crypts become deeper, and there is an increase in diameter and slightly an increase in the length of the bowel that's remaining. There is functionally a decrease in stool volume output, an increase in nitrogen balance. There is weight gain happening, and there's a slower transit happening. And there is an expression of PEP-T1. The phases of adaptation are phase 1, which is 1 to 3 months. This is the time where they need TPN, and they're prone to very severe diarrhea and dehydration. Phase 2 takes months to years, and this is the time we start reducing the parenteral nutrition, and there's improved absorption. Phase 3 is in the second year, when parenteral nutrition is reduced to only few nights a week. What is necessary in the diet of a patient with SBS? They need to consume 2 to 3 times the usual calorie intake of another individual. They need to take small, frequent meals and ensure plenty of high salt fluid intake. The carbohydrate requirement will be 2.5 to 6 grams per kg per day. Protein will be 1 to 1.5 grams per kg per day. And fat should be low, less than 1 gram per kg per day. Polymeric diets are preferred. And if the colon is present, we can give them complex carbohydrate, low fat, and soluble fiber rather than insoluble fiber. If the colon is present, this complex carbohydrate gets converted to short-chain fatty acids, which give an extra 300,000 calories per day. If there's no colon, we can give them medium-chain triglycerides and also long-chain triglycerides. We avoid fiber in a high-output diarrhea of more than 3 liters per day. Before reducing parenteral nutrition, we should ensure that the urine output is more than 1 liter per day. The patient gets 80% of his calorie requirement enterally, and there's a positive enteral balance of 500 to 1000 ml per day. Surgical treatment of short bowel syndrome. The indications are persistent parenteral nutrition dependence, severe malabsorption, and dilated dysmotile bowel. The first thing that can be done is a re-anastomosis of the colon if that is available. This itself would increase the caloric absorption by 500 to 1000 calories a day. Tapering enteroplasty can be done, recirculating loops, colonic interposition can be done, and artificial intestinal valves can be placed. Intestinal lengthening procedure. This is the Bianchi procedure. So a dilated bowel is divided longitudinally. 2 hemiloops are created. These are re-anastomosed end to end. This doubles the bowel length. This is indicated if there is a dilated non-functioning bowel, there's dysmotility, or there's SIBO. It's mostly done in children. The STEP procedure, which is serial transverse enteroplasty, in which what they do is alternating stapler application. So they make zigzags and narrow channels. It increases the functional length by 50%, and there's better blood supply compared to the Bianchi procedure. Intestinal transplantation. The indications are parenteral nutrition dependent SBS plus a progressive liver disease, end-stage liver disease, severe dehydration despite adequate nutrition and supply, recurrent catheter sepsis or thrombosis. The types of intestinal transplantation, you can either do an isolated intestinal transplant, you can do a combined one with a liver transplant, you can do a multivisceral one as well. 46% overall survival rate, and many successfully are weaned off parenteral nutrition. The medication for adaptation includes growth hormone plus glutamine, There is a mild improvement in which there is a reduction in parenteral nutrition by 2 liters per week. Not very much, but there's a mild improvement. The side effect is fluid retention and carpal tunnel syndrome. GLP-2 analog called teduglutide. This increases the villus height and causes enhanced mucosal growth and increased absorption. The side effect of teduglutide is gallstones. Calcium oxalate kidney stones. This is seen in extensive ileal resection if the colon is preserved. It develops in 24% of these people in 2 years. The treatment is a low oxalate diet. Calcium citrate can be given orally, which binds oxalate in the gut.